Thank you so much, Dr. Brzezinski. So I'm Chris Tran. I'm an endocrinologist at the Ottawa Hospital. It's a pleasure to be here. So let's get started. We'll be talking about modern approaches to osteoporosis. I have no disclosures. And so before we just dive into the objectives, I just want to talk about why I think osteoporosis is important and why I love osteoporosis. So I tell my patients it's more than just a number on a bone density. It's more than just a T-score. You know, you're treating the person in front of you and not just a number on the computer screen. Fractures and osteoporosis can lead to morbidity and frailty, and you don't need me to be the ones that tell you that these are important in the patients we see. And it's prevalent. You know, 1 in 3 women and 1 in 5 men above age 50 will have an osteoporotic fracture. And the two things down below that are not bolded, I don't have time to talk about today, but you know, mortality is one of those things where if you have a hip fracture, you're more likely to die in the next year. But I find in practice that you can't really scare our patients with that. You know, they've sort of accepted the fact that they may pass away one day. So I tend not to talk so much about the mortality. I tend to talk about what means a lot to them, which may be their independence, and to treat them like a person, and not just a number on a screen. So this slide just says that most hip fractures happen in people who don't have osteoporosis, because remember, it's only a number on a screen. And so, you know, statistically, there are more people without osteoporosis than there are, and so therefore there's more hip fractures in people with only osteopenia, but still, it just highlights the fact that you're really treating someone and not just a number. And the morbidity is something I like to emphasize with my patients. So when I get to know them, I'll say, you know, what are your IADLs like? Do you drive a car? And do you do your own taxes? And then I tell them I have friends in Toronto that haven't figured out how to do either yet. So if they can do it, they're quite independent, and we want to keep them that way, right? I say stuff like, you know, you spend so much time helping others, and you know, I'm sure you don't want others to help you, and they all shake their heads. You know, I want them to stay as independent as possible, and so fractures are one of those things that can limit your independence. And so, for example, if you have a vertebral fracture, you might lose height, and you can't reach the things on the top of the cupboard. You know, then you'll look a bit kyphotic, and I literally, you know, I do that, and then they don't want to look like that. And then for hip fracture, you know, if that happens, one leg might be shorter than the other, despite the best surgeon out there. Almost half the time, you might use a walking aid. You won't be able to walk the same as you used to. And a quarter of the time, you just can't live on your own anymore. So that's things that I find that people take more seriously than just, you know, you might die in the next year. And then the bottom slide just says that if you compare osteoporosis with some cancers, it's quite comparable with regards to a metric called disability-adjusted life years. So it's up there, and not to be taken too lightly. And this is basically stolen from Dr. Ruth Ellen's academic grand rounds a few years ago, but you know, no talk about osteoporosis and fractures would be without frailty. And it's just to show that a lot of the people we see are either frail or pre-frail, and falls, fracture, and disability, it's all one vicious cycle. So if we can break the cycle somewhere, you know, we should. So I'm here to talk to you about the fracture side of things. Also stolen from one of the geriatrician's grand rounds is this slide from Dr. Spielg. So I can talk on and on and on about osteoporosis and why I think it's important, but let's just aim for some quick wins and maybe some things that you might be able to remember after this talk. And so to focus my objectives, this is literally an email I sent to Dr. Brzezinski, and says, and she said, here's what I want to talk, or here's what we want you to talk about. So just to summarize, we'll be talking about how to approach a moderate risk patient. This is a common question that's asked of me. And so I figure we can talk about some of the guidelines that are out there to help us approach this moderate risk patient. We'll also want to talk about when might you not choose medication for someone, and maybe when might you not want to do a bone density. You know, in a world where resources are getting lower and we want to choose wisely, you know, we don't have to blindly treat people or blindly do a bone density in them. And then there's something called a bisphosphonated holiday. For those of you who are not aware, we'll talk about this in a bit. But I find that I'm stopping medications as often as I'm starting them, which is another favorite part of my job. And then to talk about some of the newer therapies that are on the horizon and how they might change future practice. But spoiler alert, they probably won't, and you'll see why soon. Long story short, a lot of the medications we have are quite good. And the ones that are coming out are going to be quite expensive. So let's talk about an approach to a moderate risk patient. So if those who aren't familiar, there are two main risk calculator scores we can use. So one's called Geriatric. It's the easiest of the two. You take sex and age, femoral neck bone density score, and then you plot them on this chart. And so you either land on low, moderate, or high. If it's low risk, don't treat. If it's high risk, you might want to treat. And if moderate, there's certain people you would treat and maybe some you won't. And you add a category if you've had a significant fracture or if you're on a significant amount of corticosteroids. And so I tell people what is a significant fracture. You know, there's 206 bones in your body, so they can't all count. So the ones that I think count are, you know, the really bad ones, so your hip and your spine, but also your distal wrist and your proximal humerus. So those are the ones that have been shown to predict future fractures. But things like rib and ankle, you know, fingers, although they might be significant to the patient, they haven't really been shown to, one, predict future fractures, or two, be preventable with medications. Another way to do a risk calculation is FRAX, and so it's a bit more time intensive, but not that much longer. You just put a few more demographic information, and then whether or not they had a fracture and so on. Great thing about FRAX is that you don't need a bone density to calculate a risk score. You know, so if you're thinking about doing a bone density in someone because you want to know what the risk score is, but it's the dead of winter, you don't want them to, you know, trip on the way to the bone density machine, you can use this FRAX score to see what their risk is without bone density. And it will spit out a number for you. If it's more than 20% 10-year risk for a major osteoporotic fracture, you're high risk. Less than 10% low risk, and anywhere in between, you're moderate risk. So again, low risk, don't treat. High risk, you should treat. Moderate, have a discussion with the patient. And so there are many, many, many guidelines out there. So another thing I like about osteoporosis is just that. And so what you do is you read all the guidelines and you pick and choose the things you like, and therefore you're always following the guidelines. But I just wanted to introduce to you some of the ones that are more commonly used. And so we have to talk about the Canadian guidelines. So they say that once you hit 65, everyone should have their first bone density, and then you can get it earlier if you have certain criteria. And so I highlighted the two Geriatric risk calculators here, basically to show you that if you're in osteoporosis range, so a T-score less than or equal to -2.5, you're at least going to be moderate risk. And the guidelines also say if you have this score at any site, so spine or total hip, not just femoral neck, you should be considered at least moderate risk. And so here's a busy slide for you, but I like bringing up this one a lot of the time because my favorite part is here, this red box that says always consider patient preference. So if you go through everything with your patients and you explain it to them in a way they can understand, and they make an informed decision not to go on medication, that's okay. There are certain conditions where you might want to think about treating a moderate risk patient, and so you can go through them all. But remember, even if they don't fit any of these things, there's still an arrow that says they may benefit from pharmacotherapy. So as we know in medicine, not everything is black and white. You know, there's no multiple choice question here. It's very much a lot of gray. And so, yeah, you can argue to treat, but also not unreasonable to go to just watch and wait. So our job is to basically tell our patients, here are your risks and benefits. You might benefit from it, maybe not as much as if you were a high risk. But if you choose not to go on the medication after hearing what we had to say, that's okay. And so what do you do with a medium risk patient? If they want to think about medication in the future, just not now, you can repeat your bone density later and see how things go. So I had a bone colleague that says, I don't treat any moderate risk patients, so it's a bit more extreme. But you sort of get the picture. You don't have to treat people. These medications are not life-sustaining. So I tell people you don't need them, but they may help you maintain your independence, which is why you're here. We want to keep you independent and driving and not relying on others. So the NOF is in the States, and so they say everyone gets a bone density at 65 if you're a female, and then 70 if you're male, which makes sense to me. If you're, so remember, less men fracture, so maybe you can delay your first bone density until age 70. And they don't use CAROC per se, that's more Canadian, but they just simply say if you've had any hip or vertebral fracture, treat that person. So Canada does the same. These automatically, if you have one of these, you're automatically high risk, no matter what your bone density is. They say if you have osteoporosis at any site, you can consider treatment. So this is not in our guidelines, but remember, our guidelines indirectly say this. If you have any one of these scores, you're at least moderate risk, and a moderate risk patient might benefit from therapy. And then here they say if you don't have osteoporosis, but if you do the FRAX calculation and you turn out to be high risk for a fracture, then treat that person. I didn't mention this, but the FRAX calculator also tells you what your hip fracture score is as well. It's not in the Canadian guidelines, but we can use it as well. The threshold for high risk is 3%, and there's no medium risk. You're either high risk or not. And so these are the National Osteoporosis Guideline Group. This is in the UK, and so they don't say, here's when you do a bone density. They have two different thresholds just to confuse you. And so one threshold says, when do you do a bone density? So it's not just blindly at age 65. And the intervention threshold is when to treat. So what you do is you see a patient, you talk about their clinical risk factors, and then you apply the FRAX score. Remember, you don't need a bone density. If you're high risk, just treat them without a bone density, although you might want to get one just to demonstrate a response to therapy. If they're low, you don't have to bother with a bone density. So that makes sense. So if you have a lot of 65-year-olds that are otherwise low risk for fracture, then you hear a bunch of bone densities you didn't have to do. But if they're anywhere in the middle, you do a bone density, and then you put that bone density score into your FRAX calculator. If they're high, then treat. If they're low, you don't have to. And so this graphic, which is surprisingly not intuitive, it took me a long time to go through this, but basically, let's say you're seeing a 65-year-old woman for the very first time in your clinic, and you want to decide, are they high risk for fracture or not? Before you do your bone density, you just put all of her demographics into the FRAX calculator, and it will spit you out a number. So it'll spit you out a 10-year risk of fracture. So if you follow 65 and it kind of lands in 20, if it's more than 20, you might treat her. And if it's less than, let's say, 7 or 8%, you won't. But if it's somewhere in the middle, that's when you'll get your bone density score. And this is what this dotted line is. So once you get your bone density score, you throw it back into FRAX. And if it's above this line, you might want to treat. If it's below, maybe not. So yes, it took me a while to go through this, but it finally made sense to me. And the final list of guidelines I want to talk about they came out recently, so 2017. This is the American College of Physicians. They're not quite endocrinologists or rheumatologists, they're more family physicians, but they sparked a lot of debate among some bone experts. So the first one's pretty straightforward. Your first line therapy for medications and osteoporosis in a female is an anti-resorptive, so that's a bisphosphonate such as risedronate, the trade name is Actonel, or alendronate, and the trade name is Fosamax. And then you can also use the denosumab, and the trade name for that is Prolia. They say treat a woman for 5 years, but they don't say what happens after 5 years. So, if you see someone who's 70, they're going to make it till 75. What do you do after? The guidelines don't actually tell you. And then in men, they say use a bisphosphonate, so they don't go outright to use denosumab or Prolia. I think the reason why they said this is because we have a lot more data on the bisphosphonates versus denosumab in men. So there's a lot more data in women. There's some data in men. But, I'll tell you, we do use denosumab in men as well. This one has sparked a bit of controversy. So once you start someone on a medication, they say don't do a bone density again, right? So if you think about it, you're trusting that this person will actually take their medication, but like other medications, the adherence rates to these medications are not that high. And so after 1 year, it's thought that about 50% just aren't taking their medications as prescribed. And then around 2-year mark, only about a quarter of your patients are actually taking it. So, how do you determine this? You can go through pharmacy registries, how often are they filling out their prescriptions, but they're just not fully adherent. And, it makes sense. You don't feel your bones getting stronger, right? Same with a lot of diabetes medications, blood pressure pills, cholesterol pills. You don't feel yourself getting stronger. So the argument to do a bone density is to, if it shows that the bone density goes down, then you might want to ask him, are you taking it properly? But this guideline says don't bother doing it, just assume they're taking it all the time. So I'll tell you, a lot of people won't follow this one per se. I personally will do one 1 or 2 years after they've been on treatment just to demonstrate a response. And if you have, then you probably don't need one for quite some time. But if you haven't shown a response, then maybe they're not taking it as prescribed, or maybe you missed another cause of osteoporosis. And here, they are against what's called MHT, so menopausal hormone therapy. So this is your traditional HRT, so hormone replacement therapy. That was later, the name of that was changed to EPT, which is estrogen progesterone therapy. And to just confuse all of us, they changed it again to MHT. So this is estrogen and progesterone for postmenopausal women. And they're also against raloxifene, which is a SERM, a selective estrogen receptor modulator, also used for osteoporosis. Our Canadian guidelines say, yeah, it works just fine. It may not be as strong as the other ones, but it works. So if you have a woman that doesn't want to be on these medications, but might want to go on this once a day because it might prevent some breast cancer, then I think it's worth going on it. But these guidelines say just don't even bother using this. And the final one, we don't have to talk about, it sort of makes sense, base your decisions on all these things. So I'm not going to go through these ones, but I just wanted to highlight these 5 recommendations, and some of them are actually quite controversial. So then the answer is, why don't we just treat everyone, right? These medications have a fairly good safety profile. A lot of the patients we see are otherwise moderate risk, and so if you're medium risk, you have a favorable benefit to risk ratio, right? So why don't we just treat everyone? Most guidelines say treat if the person has osteoporosis. If you look deeply into a bone mineral density report, you're probably going to find a score that is osteoporotic. So why don't we just treat everyone, right? So the next slide is just when not to treat, right? So again, we're not here to just treat the numbers, right? We need to treat the person in front of us. And so this slide here is just to show, we want to be mindful of polypharmacy and always consider the patient too. So again, if you describe the risks and benefits to your patient, even if they're high risk, if they don't want to go on the medication, you can't force it upon them. And if they leave with a prescription, but you didn't explain to them why they might want to be on it, they might not feel it, or they might not even take it. Of course, don't treat someone who's low risk for fracture. So when does this apply? Many years ago, maybe 10 or 20, a lot of people would just be put on this medication and then no one would re-explore it. And so when you dig back in the past, maybe they weren't even medium or high risk for fracture to begin with. They were just started on it for an unclear reason. And so that person, you can actually stop their medication if you look back. And here, if like I said, one of my bone colleagues said, I don't treat moderate risk patients, but the patient where you might want to treat if they're moderate risk is someone who's considered high imminent risk. So in our world, we have a joke, bones are slow, they don't really do anything, but who's high risk for fracture, like really high? Someone who might fracture in the next year, someone who's had a recent fracture, so spine or hip, someone who falls a lot, and people in this room can tell me about this more than I can, and anyone who's on steroids. So in the younger audience, people who are on internal medicine, it's basically a vertebral fracture is a rule rather than the exception if someone's on a lot of steroids. So if you don't have any of these, then and they're otherwise moderate risk, you might not have to treat that person. And remember, there's non-pharmacologic treatment for everyone. I've been focusing so much on the drugs, but there is a lot of non-drug pharmacy for people. So calcium and vitamin D. So I could talk to you for a whole hour about these two. Long story short, no one has shown that calcium prevents fractures, and no one has shown that vitamin D prevents fractures. But when you put the two together, you can prevent a hip fracture. And just because it has been shown doesn't mean it won't work. So it makes sense that you need a bit of calcium and vitamin D in your diet. But what I tell my patients is that, yes, the guidelines do emphasize 1,200 milligrams a day of calcium, you get 300 without trying, and so that means you need 3 good dairy sources. But if you can only get to about 800 a day, that's probably good enough if your vitamin D is okay, right? So you don't have to go too crazy on the milk or supplements. If you get 800, you're probably good. And so don't lose sleep over how much calcium you're taking. Exercise is great. I say to the patients, don't just do it for your bones, do it for your heart, do it for your mood, do it for your brain, and do something that you actually enjoy doing, otherwise you'll stop doing it. Again, falls prevention, I'll be honest, I don't have much time to go over this with my patients, but anyone who falls 2 or more times per year is considered high risk for falls. And so those 2 risk calculators we talked about, they don't incorporate falls when you're trying to calculate risk. So if you're medium risk but have lots of falls, maybe consider that medication. And don't smoke and don't drink too much. So how much alcohol do you have to drink to harm your bones? It's 3 units per day, so that's quite a lot. So I don't tell people you can have 20 units in a week, you'll be fine, but be sensible. So for the record, no more than 9 per week if you're a female, and no more than 14 if you're a male. But for the bones, you can go all the way up to 21. So when should you bone density someone? So this is more my own opinion. So don't order a test unless it changes your management, right? So if you're going to get a bone density, only do it if it's going to make a change in your management. So if someone swears up and down that they don't want any medication ever in their life, then do you really need to get a bone density? If you're low risk, you can wait a full 5 years. And the reason why I have this one here is, let's say that you're low risk and you're here. Even if you were to wait 5 full years, and if your T-score were to drop a whole point, you would still be in the not high-risk category. So that's why you can wait a full 5 years. It sounds like a long time, but remember, bones are pretty slow. And the medium-risk patients, it does say 1 to 3 years, so how do you decide between the two? You can just say the number in between, which is 2 years, or you can see exactly where they are. So if you have a woman who's close to the high-risk range, then maybe you get it a bit sooner, or maybe even treat that patient. But if they're on a lower end of moderate risk, you can probably wait another 3 years. And this is what I do in my clinic. I bring this up and I show them, look, if we add 3 years to your life and subtract a little bit of your T-score, you're still in the medium risk category. Remember, you can frax without that bone density. And so, so if it turns out their 1 year bone density is, January, February, and you don't want them to come out of their house and trip and fall on the way to their bone density clinic, you can defer it until May or June, and you can always use the frax without a bone density. Remember, you can only use these if they're not on medication, but we do it all the time. And here is, this is something I started doing, and I'll be honest, I haven't talked to too many bone colleagues about this, but I would actually actively recommend against bone densities for these following reasons. So if you've already demonstrated responsive therapy, so you put someone on a pill once a week or once a month, and you have 2 bone densities, 1 before, 1 after, and it's working, then why bother doing so many bone densities afterwards just to show that it's still working, right? Even if the bone density goes down on one of the pills for osteoporosis, they're still getting some fracture protection. So a good example would be denosumab, which is every 6-month injection. And if they're going to be on it for 10 years, you don't have to get a bone density every time. So once I demonstrate responsive therapy on denosumab, I just say, hey, no more bone densities for you unless you're going to change your medication. And this one's maybe a bit more controversial, but if you have someone who's high risk, someone who's had a vertebral fracture and you think they would really benefit from medication, but despite your informed discussion that they should be on it, they don't want to go on medication, then I just basically say, hey, look, no more bone density for you, because we already know you're high risk. It doesn't matter what your bone density says. Even if it magically gets better, you're still high risk. So I've had 2 women where I said that to them, I think you're very high risk, and all the bone densities you're past, it doesn't matter, you're high risk. And once you tell them no more bone densities in your life, they just change their mind and say, okay, I'll go on the medication. So I'm not sure why that happens, but I do tell them, like, it's not going to change your management, right? So we'll go on to the bisphosphonate holidays. This is an article from the New York Times, and it's great because they explain medical terms in layman's terms. So, there's reports that these drugs can cause the jawbones to rot. So that's ONJ, or osteonecrosis of the jaw. or your thigh bones to snap in two, so that's a typical femoral fracture. So people who don't want to take your medications, they're going to look online and find reasons not to take it, right? And so these are the reasons why. So this is an atypical fracture, and they're awful, but they do happen. Even in people who don't go on osteoporosis medications, just remember that. And this is ONJ, which looks pretty bad. And this basically only happens because of these medications. But we have to discuss the risk of harm and the risk of benefit, right? So this means number needed to treat and number needed to harm. So if you're not familiar, you need to treat 50 women to prevent one fracture. And then you need to treat 40,000 of them to cause one fracture. So it depends on my mood that day, but I might say, for every 800 fractures we prevent, we might cause one. And so here it says use real-world examples. So you can try to explain this to patients. After 5 years of bisphosphonate, your chance of an atypical fracture is 1 in 5,000. But 1 in 5,000 sounds pretty often, even though it's not. So this is what I do. I like to use Canadian references. So if it's roll up the rim time, I know that if you roll up the rim 4 times in a row and win 4 times in a row, that's about 1 in 1,000. So I'll just tell them, have you ever rolled up the rim to win? Have you ever won 4 times in a row? And they'll say no. And then I'll say you're more likely to win 4 times in a row than to sustain an atypical fracture after 5 years. Another way you can do it is quarters, right? So I say, you can take 10 quarters or 12 quarters, throw them all in the air, and if they land on heads every single time. So 12 quarters every single time is heads, that's 1 in 4,000. That's still less likely than an atypical fracture. So go home and do that, and if you give up, you've got $3, you can buy yourself a coffee and roll up the rim to win. So anyway, this is what I have discussions with my patients. Another way you might want to try to do it is to try to find an incidence that's out there. So, a chance of a man dying from breast cancer is 1 in 5,000, right? So, and most people don't know a man who does have breast cancer, which is 1 in 1,000. And if I also, a cute way of saying things, let's say, do you know anyone who's going to give birth soon? If they say yes, then I say the chance of them having a 6th toe is 1 in 500. So, so these events, although they happen, and we hate it when they happen because, we all took an oath to not harm a patient, overall the benefit does outweigh the risk if you treat the right people. So this is from the American AACE guidelines that I didn't talk about much, but this is basically comparing osteoporosis medications with wearing a seatbelt. This is how many injuries and deaths happen if you don't wear a seatbelt. And if you do wear a seatbelt, if everyone wears a seatbelt, you can cut it by half. So you don't prevent them all, but you can prevent a lot of injuries. And this is how many injuries happen because you were wearing a seatbelt, right? And so the same thing with osteoporosis. If we treat no one, this is how many fractures happen. If we treat everyone, we'll prevent some fractures, not all. And then this is the amount of fractures and bad events we can cause, all right? And so even though the risks are really small, to us they seem small, but for our patients they may be astronomical. So we need to show them that we're on their side. And so these bisphosphonates, they're great, they're sticky, they stay in your bones for quite some time. So even if you stop it after they've been on it for 5 years, they may stick around for 1, 2, maybe 3 years. And if they're on the intravenous bisphosphonate, maybe 5 years. And so if you stop it, you still might get the fracture protection, and you might, quote unquote, reset that clock for that risk of one of these 2 bad outcomes. So you may reduce the risk of 70% after a year off your medication. So remember, the risk is still very small, but you can reduce it even further. But a key thing to remember is that you can't do this drug holiday in someone with on denosumab. Okay, so we used to do it for everyone, whether or not they're on a bisphosphonate or denosumab. But then we realized that denosumab is actually quite reversible. And so by reversible, if you go on denosumab, it means your bone density climbs really nicely, and it'll continue to climb up to 10 years. But if you stop it cold turkey, your bone density will drop pretty fast. And then during this time, I call it the denosumab off period. Your bone turnover is really fast. And so during that time, you might actually be at risk for something called rebound vertebral fractures. And so this has been described by a lot of a lot of studies. So if you stop it cold turkey, you may cause all these vertebral fractures. So have I seen it? Well, it's hard to really pinpoint the cause. But yeah, I've seen it 2 or 3 women where you have all these different vertebral fractures in different spots for no reason. And then you look back and they were on denosumab that was just stopped cold turkey. So basically, if you're going to go on denosumab, you need to stay on it indefinitely. But if you want to stop it, then 6 months after your last dose, you might want to go on another drug for osteoporosis to sort of blunt this off period. And so the challenges of the bisphosphonate holiday is no one knows when to do it and no one knows how long, because remember, bones are slow. If you really wanted to find the answer to this, you'd have to follow women for a long period of time and follow a lot of them. And so a lot of this, what we talk about is expert opinion. But let's say consider holiday in most patients or all patients between 3 and 5 years on therapy. But if they're high risk, maybe up to 10 years. And how long is your bisphosphonate holiday? Again, not clear, but most people can go 1 to 2 years, and you'll see some guidelines say even up to 3 years. And then you might say, hey, maybe I'll just bone density that person or do bone turnover markers every year while they're on their holiday. But it turns out that approach, you can't really predict who's going to fracture or not. So it's still a little bit up in the air. But I still tell my patients, it's not a bad idea if you're not high risk to give your bones a rest from the medications. I used to say give your bones a break from the medication, but that was a poor choice of words. And so this is something from the ASBMR guidelines. That's the American Society for Bone and Metabolic Research. And so basically they say if your woman's been on a pill for osteoporosis for 5 years or intravenously for 3 years, if they haven't had any fractures, so this is no, and all of their hip bone density scores are not in the osteoporosis range and they're not high risk, then you can stop their medication for up to 2 or 3 years. And I think these are a lot of women that are out there and not the ones that are seen in my clinic. And so if they fit any of the other categories, they might want to see a bone specialist. But yeah, most women who are on it, they may have had osteoporosis to begin with, and then you treat them for 5 years and they no longer have it on their bone density score, and then you can stop after 5 years of therapy. And so a quick summary of what we just talked about. So after 5 years, if they're not high risk, just stop it for a year or 2. But there's always a plan that they might go back on it. So another bone expert would say it's not a retirement, it's more of a sabbatical. Just a holiday from the medication. But after 10 years, if you've been on the medication consecutively for 10 years, no one has shown that the medication can actually prevent fractures at that point. So even in the highest risk patients, you might want to consider a little bit of a holiday after 10 years. But if you're not sure, just refer to one of us. And how long does the holiday last for? If you're otherwise a straightforward person, 2, if not 3 years, because we know the medications are pretty sticky. But remember, you don't want to do the holiday in someone who's on Prolia or denosumab. But if you want to stop the medication for whatever reason, then you might want to put them on a bisphosphonate after their next scheduled dose of denosumab. All right, and so the final thing I wanted to talk about, another modern approach, is the upcoming medications that we have. And we're doing okay for time. So this is, I call this the bone orchestra. So if you ever wondered how bones are formed, you have your bone builders, your osteoblasts, and your bone chewers, your osteoclasts. And they all work together. This is, at the bottom is something called an osteocyte. So these are actually the bosses. They make sure everyone is working well. And so these respond to mechanical stresses. So this is why we stress exercise. If you don't use it, you lose it. If you don't apply mechanical load on your bones, then these osteocytes won't be activated and they won't tell these cells to work. But it's all a concert of bone building and bone chewing. And you need a little bit of both, right? So it's kind of like painting a wall in your room. You have your painters and your cleaners, right? So you don't want too much painting, you don't want too much cleaning, you want a little bit of both. And so if you ever wondered how the bisphosphonates work, they basically get into the bone chewers and they block the rate determining step of an enzyme that determines their longevity. So if you block that, you'll kill a whole bunch of them. And so I wanted to talk about the newer targets. And so there's an enzyme called cathepsin K, which secretes some of the acid that bone chewers use to chew up your bone. So if you block it, then maybe you'll have less bone chewing effect, and then you'll prevent fractures, because after menopause, you lose all your estrogen, and then your bone orchestra, which is what I call it, doesn't work as well. and then your bone chewers just wreak havoc on everything. So if you slow down your bone chewers, maybe you'll get less fractures. So that's what happened when you actually block the cathepsin K. But it was a very grim day last year when they realized that these medications in the phase 3 trial were associated with more increased risk of stroke, and no one knows why. And so this had a really good anti-fracture efficacy. It was an oral drug. People were quite excited about it, but when it made it to phase 3 trials, there was too many strokes in the treatment arm. And so I don't think there's going to be any of these inhibitors anytime soon. But there are two that are out there, and one's called antisclerostin and one called parathyroid hormone-related peptide analogs. And these are the two names. So I'll quickly go over these, just so you know. If anyone asks you what are some of the new medications out there, you can talk a little bit about them. And so this is the Wnt beta-catenin pathway. And so this is on your osteoblast. So when it's active, you have Wnt that binds to frizzled, which is a protein in the cell membrane. It'll tell this beta-catenin to go to the nucleus and then secrete something called osteoprotegerin. And so these medications will basically keep the osteoclasts from not being activated. And so if you have more osteoblasts versus osteoclasts, more builders than chewers, then you might get more bone density. So you can imagine if you block this whole pathway, you might get less of this OPG, and then you'll get more bone chewers, and then you'll get less bone density. And so that's how the new medication sort of works. So it turns out there are these two other proteins that can interfere with this. So remember, in your body, it's always a balance between on and off, and so your body needs ways to turn things on and off at the same time. And so there's something called sclerostin that will block the Wnt from binding. So once it's sitting here, this beta-catenin can't go on the nucleus. It just gets chewed up, and then you can't make this OPG, which you need to keep the bone chewers from going crazy. So if you block the blocker with something called romosozumab, then maybe you'll let this Wnt bind, and you'll get more osteoprotegerin, and then less bone chewing and more bone forming. So this seems like a busy slide, but long story short, this is a big trial that came out 2 years ago where they took women who were, most of them were 71 or more, and half of them got romosozumab and half of them got a placebo for 1 whole year. And then after that, everyone got denosumab. So it's hard to do randomized controlled studies that have placebo arms these days, especially when you have something else out there. So the reason why you had to have these two was you had to give everyone an established medication. So the fact that they were able to recruit people for 1 year without medication was pretty good. So basically, if you look at the two groups, the group that wasn't placebo, the group that got romosozumab, their bone density scores went up quite a lot, both at the spine and at the neck. So the numbers got better. And then, did they fracture less? And the answer is yes, absolutely. So in the romosozumab arm, you had 73% chance of having a vertebral fracture in the first year. And if you followed everyone out for 2 years, that risk would continue. So about 75% chance less fractures if you're on the treatment arm or not. So these medications work. And so they only looked at vertebral fractures. Remember, bones are very slow. It's hard to show that medications work because the fracture rates are so low. And so vertebral fractures happen the most often. That's why the trials look at vertebral fractures. If you look at all the other fractures, maybe there's some signal that the romosozumab does work. But if you look at all the fractures that were not the vertebral fractures, then there wasn't a significant response. It looks like it sort of drifts off, but if you look at the actual graph, there's not much of a difference. So why didn't this happen? So there's two other trials, the ones that looked at denosumab or Prolia, or zoledronic acid or aclasta. Those trials were much longer. They were 3 full years. So those trials were able to show fracture efficacy basically across the board. Whereas this new drug only showed a benefit in vertebral fractures. Well, it's thought that because maybe they recruited less sick patients, so the healthier your patients are, the less likely they're going to fracture, the harder it is to show that your medication works. And if you follow them for shorter, you might not see that outcome. So only 2% of everyone in this study got a fracture, right? Whereas a higher percentage in the other studies. And this is just a really quick table to say that there's no big adverse events when you compare the two. So another study came out with romosozumab. This time it was alendronate, the pill. And so half the women got alendronate, and then half of them got romosozumab for a year, and then everyone got alendronate afterwards. So a 3-year study. The women were a little bit sicker, a tad older. So the previous study didn't have too many fractures, but these women, their frac scores were pretty high, from 10 to 30%. And most of them actually had a vertebral fracture. So now we're working with a population that is actually higher risk for fracture. And so maybe you can't do a placebo group in these people. And then you can try to see if you have less fractures in a sicker group. And so the answer is, yeah, you can. And so so maybe you don't see as much fracture lowering versus the first study, because the first study was a placebo control group. And this time you're comparing drug versus drug. And so one drug is stronger than the other. About 37% vertebral fracture at 1 year and 48% at 2 years. And if you look at all the fractures, you can actually prevent basically all the fractures they looked at when you follow someone for 3 years. But the big thing that came out was this adjudicated serious CV events. So when you zoom in really closely, the people who got the romosozumab, they were more likely to get either a cardiac ischemic event or a cerebral vascular event. So the numbers themselves are not that big, 0.8% in one group, 0.3% in the other. But statistically, they're significant. And so this medication is still being stalled right now just because of this signal alone. So it's not clear why the medication causes more cardiovascular events. They didn't see it in the FRAME study, which is the first study we talked about. If you look at the population between the two, yeah, one group is sicker, but there was no difference in age and in their cardiovascular background. So maybe they thought, okay, maybe because one group got the alendronate for the first year, maybe alendronate can reduce your cardiovascular risk. The answer is, well, we don't know that. And if you look at all the studies on that, it hasn't been shown that this drug can cause less cardiovascular risk. And there's something called Van-Buchem disease. I've never seen it, but if you remember in that physiology slide, if you have too much of that sclerostin protein, because you have a genetic mutation that makes too much, you can actually get really high bone densities as a kid. And this is someone's skull who has it, so it just shows that the skull is actually quite thick. But these people who have it, very rare, but when they do have it, they're not at increased risk for cardiovascular disease. So it's unclear why this happened, but it's stalling this medication from being released in full scale. But it's great for your bone density, it's great for your fractures. The other medications that's out right now is something called the parathyroid hormone analog. So long story short, if you have parathyroid hormone, you secrete a lot of something called rank ligand. So this is the opposite of OPG or osteoporosis. So if you have a lot of this around, you can get more bone chewing. So how denosumab works is it actually binds these rank ligands, so there's less of them around, and you get less bone chewing. So it turns out if you make something that looks exactly like parathyroid hormone, but you give it in a low dose intermittently, so not all the time, just once a day, this is so basically if that happens, you'll get less signaling, and then you'll get less rank ligand. So this receptor here, it's sensitive to how long the medication sits on it, if it goes on and off, on and off. And so it turns out if you have this new one called abaloparatide, maybe it's even lower dose, and it's even more intermittent binding. You'll get less signaling, and you'll get even less rank ligand. So the less rank ligand you have around, the more bone formation there is. So they've made this, and they've done trials. And so the trial is called ACTIVE. And this is a 3-pronged group. So basically, a third of women get the abaloparatide, half of them get teriparatide, which is parathyroid hormone. And we actually have this one available in Canada, and it's called Forteo. And a third of them got a placebo medication. And so, when you compare the treatment arms versus placebo, no surprise, you get increases in your bone density. And maybe the newer drug is doing a little bit better than the older drug that's out there. And if you look at the fractures are actually quite good. And so, you can reduce the number of fractures, vertebral fractures, by quite a bit. So the placebo group, 30 fractures happen, and the treatment group, only 4. And same thing with your non-vertebral fractures, you can prevent quite a bit. So 86% less vertebral fractures with the abaloperitide and 43% less non-vertebral fractures. And this is just looking at all the fractures that are out there. So again, the higher the worse, right? Because you don't want to have more fractures. The teriparatide Forteo was able to reduce fractures, but the abaloperitide was able to reduce even more. So this just says 70% versus placebo. So this medication does seem to work, and the main side effects are dizziness and palpitations, and maybe a high calcium. But with the teriparatide, which is the one that's available, we knew this was going to happen. So maybe they happen a bit more often. So in summary, this is, with 10 minutes left, is just these new medications are out there. They can prevent fractures, but one of them, which is the romosozumab, which is once a month, there might be a cardiovascular risk, so it's not going to hit prime time anytime soon. And the other one is actually available in the States, and it can prevent fractures by quite a bit and have some side effects. And so this is my last slide. It basically says that, is this going to change our management? Well, it turns out that the order does matter. So the medications we talked about are bone-forming ones, and the ones that we have out there are more what they're called anti-resorptives. So if you use the bone-forming ones first for a year or two, and then you lock in your gains with an anti-resorptive, you're more likely to get a lot more bone density gains and less fractures. So in an ideal world, you would give someone a more expensive drug, the injections, and then switch them over to the ones that we have available. So this is why I don't think that it's going to change our management anytime soon. When you see a woman for the first time, you can try to say, well, if you take this much more expensive medication, which is an injection once a day or once a month, for 1 or 2 years, and then you go to another medication to lock in your gains, that's the best way to go. Or you just do what we've been doing for the past 10 years, and you'll still get some pretty good anti-fracture efficacy. And so this is just to highlight at the bottom that, the Romo is not available yet. It may not be ever. And then the Abalo is not available in Canada yet. And the one that we do have is teriparatide. It's $1,000 a month. The exceptional access program might cover it, but you have to fit very strict criteria. And one of them is the ONJ, or atypical fracture. So again, these are really rare. So I've only filled out 2 of these in the past 2 years for patients I saw who fit these criteria. And that's it for me. So I'll be happy to take some questions. And these are just my objectives.